Hello everyone. My name is Simran Chaudhary and I welcome you all on behalf of Voice of Healthcare to this virtual panel discussion on bridging the diagnostic gap in multiple myeloma, organized by Voice of Healthcare and supported by Sebia. And today we are honored to be joined by a distinguished panel of experts representing key specialities involved in early detection and diagnosis of multiple myeloma. So let me take a moment to introduce our speakers. Dr. Rahul Bhargava, Principal Director and Chief-Haematology at Fortis Hospital, Gurugram. Welcome to our show, sir. It's a pleasure having you here.
Thank you.
Thank you so much, sir. Dr. Sushila Kataria, Senior Director, Internal Medicine, Medanta, the Medicity. Welcome to our show, ma'am. It's a pleasure having you.
Thank you, Simran.
Thank you so much, ma'am. Dr. Puneet Girdhar, Principal Director and Head Ortho Spine, MIS and Robotic Spine Surgery at BLK-Max Super Speciality Hospital, Delhi. Welcome, Dr. Puneet. Thank you so much for coming to the show.
Thank you. Thank you to you, Simran, and I'm happy to join an esteemed fraternity on the panel today.
Thank you so much, sir. Dr. Sujay Prasad, Director, Neuberg, Anand Reference Laboratory, Bangalore. Welcome, Dr. Prasad. Thank you so much for joining. Thank you so much, sir. Dr. Ashwini Gadde, Consultant Nephrology, Fortis Hospital, Gurugram. Welcome, Dr. Gadde.
Thank you.
Thank you so much, ma'am. Thank you so much for joining. And Dr. Siddhartha Sharma, Moderator, Head and Clinical and Scientific Affairs, Sebia, India. Welcome, Dr. Siddhartha.
Thank you, Simran. Happy to be here and very honored to moderate this esteemed panel discussion. I mean, with such star panelists on board. So yes, happy to be here. Thank you.
Thank you so much, sir. So, like Dr. Siddhartha mentioned, each of these esteemed professionals brings a unique lens to the table, and we look forward to an engaging and insightful discussion on improving diagnostic pathways for multiple myeloma through this multi-speciality collaboration. Now, I hand over this panel to Dr. Siddhartha to take it ahead. Thank you so much, sir.
Thank you, Simran, and good evening, all of you. As I stated, very happy to be in the midst of all of you. So to set the ball rolling, let me do a bit of a context setting before we get down into the nitty-gritties of this panel discussion. So at the beginning, let me start by stating that multiple myeloma, being the second most common hematological malignancy, has a highly variable presentation which mimics signs and symptoms of many common diseases such as diabetes, arthritis, and chronic renal insufficiency. As most of the patients who are diagnosed with multiple myeloma initially present to the primary care physicians and clinicians and other specialities with such varied manifestations, the physicians should be quite adept in recognizing the typical signs and symptoms of this disease. And as of now, the researchers are of the opinion that multiple myeloma is difficult to treat because the physicians usually delay treatment until the symptoms of myeloma end organ damage are detected. So, therefore, it becomes very imperative to start detecting and treating early stage multiple myeloma in the groups of people who are at the highest stress so that they are provided with the best chance of remission and cure from this disease. So, therefore, to deliberate more on this, I will initiate this panel discussion now, which has top healthcare professionals as panelists who are dealing with multiple myeloma in its varied forms and are here to delve more into this topic and discuss on the current challenges which they face and the possible solutions for the same. So, to start with, I will now start and put my questions to Dr. Rahul Bhargav. Dr. Rahul, my first question to you is, as a clinical hematologist in a reputed corporate hospital, What are the challenges that you have observed in the delayed referral of myeloma patients from primary care physicians and other clinical specialities to you for management? Over to you, Dr. Rahul.
Dr. Siddharth, very nice question and welcome to all my panelists. So the challenges are abound in this country because of the virtue of health has just become a priority in past 5 years. First biggest challenge in India is that we have a very younger population. We don't have a aging population like US, where the median age of myeloma is sixth or seventh decade. India is still pretty young. So that's one of the biggest problems. Now, as the lifespan is hitting 72, we are finding more and more people coming up with various disorders to get into the modality of diagnostic. Second major problem is it is never in the differential diagnosis. Still, the tropical diseases remains a major challenge for us. So, as I say, and as you can see my social post, back pain, high ESR, anemia, think myeloma. Unexplained renal failure, think myeloma. Peripheral neuropathy, unknown cause, where you're not able to find, which is called as CIDP, think myeloma. Albumin globulin ratio reversed, myeloma. High calcium, myeloma. But at the same time, the biggest challenge is that these symptoms and these things can be of so many diseases can mimic these problems. And that is why these webinars and seminars and discussions and the social posts are very, very essential to know, to educate and collaborate with our orthopedic friends that everything is not tuberculosis, to our kidney friends. And this is not just myeloma. It is like, when you're talking about the myeloma, we should say plasma cell dyscrasias. And that will come as unexplained heart failure, amyloidosis. That will also come as MGRS, where our Dr. Ashwini will elucidate. So when you talk only myeloma, Siddharth, it is you have to talk about the plasma cell, both the quantity and the quality, which is affecting the kidneys and the heart. And that is why it is imperative. Has to be a multidisciplinary team effort, because my primary care physicians and my dear colleagues, Dr. Sushila, Kataria, still continues to send so many tons of multiple myeloma patients towards us because of our previous association. It is very essential that we need to keep myeloma upfront, or for that matter, hematological malignancies. So think lymphoma. If you have a tuberculosis, you have a lymph node, of course, tuberculosis is the first, but think lymphoma as well. So I think things are changing. Things are changing very fast. We are picking up myelomas at really very fast pace. And you'll be amazed that yesterday, US FDA gave an approval for daratumumab in smoldering multiple myeloma.
Okay.
And we are still searching for our MGUS and smoldering myelomas.
Right.
See, we are only getting myelomas. We are still way, way behind in picking up those pre-clinical diseases burden, where we should be picking it up and trying to understand they should not progress to myeloma. So it's a fantastic world. I think future is bright, and our colleagues are well-learned colleagues, which are at a drop of things, they can pick it up.
No, right. Very well said, Dr. Rahul. And I believe it is imperative to pick up the pre-malignant stages of myeloma, monitor them accordingly, and prevent their progression, or rather, I would say stop their progression to myeloma by offering adequate therapy, like you stated, daratumumab in smoldering myeloma. So that's a very good beginning.
So on the lighter side, Dr. Punit, we don't want any patient to go to you for a fractured spine. So I am the culprit, okay? That's the whole idea. Nobody should go to Dr. Punit because of myeloma fractured spine.
Right. Yes, that's a very big, a very big cause of morbidity in myeloma patients. So definitely, yes. So my next question to you, Dr. Rahul, is, will it be beneficial, and I guess this is from what you have already stated, will it be beneficial to screen high-risk patients for myeloma so that they can be followed up appropriately? So I guess you have
there
already...
is no high-risk patients. As a part of a preventive health checkup, which has now become a routine in the town A cities, it should be a part of it. Serum protein electrophoresis will pick up myelomas up to 80%. So it is not on-demand therapy. We should now be doing more on preventive aspect, because once we pick up these preventive cases from a preventive health checkup, we are able to avoid, by sequential monitoring this patient, from a renal failure or a fractured spine, which is leading to more of out-of-pocket expenditure. So prevention, 350 rupees test helps you to prevent tons of money which needs to be put in for treatment. As a country, I firmly believe at Fortis, the prevention is the best part in India, whether the Americans have shown or not shown the benefit of it, whether it be breast cancer screening, cervical cancer, whether it be myeloma profiles, whether it be for the cardiac risk. I got my CT angio done as a prophylactically thing day before yesterday because I had a family history. So I got that done. So more preventions you do, you will be land up saving more money in the country.
Right. So, as this old saying goes, prevention is better than cure. And I guess that holds true in every disease and more so in multiple myeloma. And serum protein electrophoresis, definitely a very simple test, a cheap test, but unfortunately very underutilized in our scenario. So, thank you, Dr. Rahul, for those inputs. So, I'll move on to the internal medicine specialist, Dr. Sushila Kataria, ma'am. So, ma'am, being an internal medicine specialist in a big corporate hospital, how do you identify patients having a potential diagnosis of multiple myeloma in your clinic? Over to you, Dr. Sushila.
Thank you very much to Voice of Health and Siddhartha for inviting me. This interesting and
Ma'am,
very useful.
there is a disturbance in your audio, ma'am. Can you check the audio, please?
Am I audible?
Yes, ma'am. I'm afraid no, ma'am. There's a lot of disturbance in the audio still.
All right. Does it look better?
Maybe, ma'am, you can switch off your camera and continue. Maybe that will save the bandwidth and the audio would be clearer then.
All right. Is it better now?
I'm sorry, ma'am. No.
Okay, I think maybe you can do with some other speakers and I will join again.
Sure, ma'am. Sure, ma'am. No worries, ma'am. I'll then jump over to Dr. Ashwini Gadde, the nephrologist on this forum. So, Dr. Ashwini, my set of questions to you is number one, as a nephrologist, can you talk about the clinical spectrum of multiple myeloma in the nephrology space? And what are the relevant investigations which need to be ordered by a nephrologist to identify such patients?
Okay. Yes, so multiple myeloma, or not even multiple myeloma, these all monoclonal proteins can involve kidney in all possible ways, literally all. It can be just electrolyte imbalances, it can be a proteinuria just, it can be a hypertension and renal dysfunction. So all sorts of renal problem, multiple myeloma or monoclonal proteins can cause in the kidney. So everything which is unexplained and not easily explained by other causes, like even in a diabetic patients, it's not like they cannot have myeloma, but there are few points that we classify the patients whether they can have the diabetic kidney disease. If there is something away from the usual, that if they don't have retinopathy, if they don't have significant proteinuria, or if I would say there is a discrepancy between urine albumin and urine protein, then we should screen for all those things. So anything which is unexplained, recurrent hypokalemias, recurrent tubulopathies, proteinuria of unknown origin, raised creatinine of unknown origin should be evaluated. And for evaluation, the primary evaluation remains the same serum assessment with comprehensive myeloma panel, which includes a protein electrophoresis, immunofixation, and serum free light chain assay. In an early stage, even urine immunofixation will help us in detecting early, though if you add all the prior 3 tests, it may not add very significantly to the value. But yes, what I want to convey here is all sorts of kidney problem can happen literally with myeloma. So everything which is unexplained to you by a usual cause, irrespective of the age, you should do the assessment for these tests. And if despite that, if it is unexplained, we ultimately go to a biopsy, and biopsy will reveal that. It's just as in biopsy also, you should have a strong suspicion of these things, because sometimes even as in there are special tests that needs to be run on the biopsy also. Sometimes on normal immunofluorescence may not give you the answer. Then you have to do a paraffin embedded block. So uh, basically you need to keep a suspicion high unless you get the answer to the cause of problem of kidney.
Right, Dr. Ashwini.
Ashwini, I
And
have a
just,
question.
yes, Dr.
Majority,
Rahul.
I mean, we have a diabetic, India being a diabetic capital, many of the people have got diabetic kidney disorders. And we have seen that as they age and they live longer, thanks to the wonderful healthcare system where Medanta, Fortis has able to provide to the people across. How do you diagnose or how do you make a suspicion of multiple myeloma in these subsets? Because there can be 3 different diseases can be there. So can you
Yes.
elucidate on that? When should we think about it? Should we think
Yes.
about it or not? How do you say?
Oh, you definitely need to think about it. So basically, to call it, obviously, as it is a diabetic related kidney disease, there are few pointers. One, the patient should have hypertension, patient should have proteinuria, patient should have other manifestations in the body of diabetes related changes like diabetic retinopathy. If none of these are present, if patient have non-proteinuric kidney disease, if he doesn't have retinopathy, if he doesn't have significant hypertension, then I am unable to confidently label that as diabetes related kidney problem. And in all those subset, I will reassess those patients for multiple myeloma. There are other pointers as well. Even in diabetic patient, if he is complaining repeatedly of backache, bone ache, etc., recurrent anemias, pancytopenias, I will screen them for multiple myeloma. So a small subset of patient, a major subset in fact, 40-50% of patients of diabetic related kidney disease, even if I am suspecting, I will end up sending all these labs just to rule that out.
Great. So, Dr. Ashwini,
Dr.
thank
Siddharth,
you.
just I'm
Yes.
interrupting in between just to check my audio. Is it better now?
Yes, ma'am. You are perfectly audible. So I will come back to you. I'll just
Sure.
finish with Dr. Ashwini and then I'll come back to you, ma'am. Thank you so much, ma'am. So, Dr. Ashwini, just out of interest, I would like to know amongst the labs which you send when you suspect multiple myeloma, how frequent do you order the complete set of investigations, which includes the SPE, the urine protein electrophoresis, and both the serum and the urine immunofixation? Because from what I have seen in my experiences, clinicians do not order as much urines as should be ordered, both protein electrophoresis as well as immunofixation when suspecting myeloma or amyloidosis. So, what is your take on that, especially the type of investigations to be ordered when you are suspecting a myeloma kidney?
Okay. So, I do agree with it that we underutilize the urinary tests. Having said that, I think serum tests, including protein electrophoresis, immunofixation, and SFLC, most of the times gives you the answer. It's the very, very small chunk of patients which might get missed on these with these tests, and in those patients, maybe doing a urine immunofixation, if your suspicion is high, might help a very small chunk of patients.
Right.
So I personally go with these 3 serum tests first, and if I'm still unanswered, then rather I will go directly to biopsy. But yes, the second set will be a urine immunofixation.
Siddharth,
Right. Yes,
sorry for
Dr. Rahul.
interrupting. At this juncture at Fortis, our motto is very simple: test more, treat less.
Correct.
The simple thing is, when people think, and there are lots of thousands of people are listening to this webinar, the message is very clear: test more, treat less. Because if you test more, you pick up the diseases early, and you have to spend less money on the treatment. And that is why even those tests seems expensive, but they are not. So serum protein electrophoresis maximum cost will be less than a slice of a pizza.
Right.
So that is why we should incorporate in the above 50 years of age evaluation serum protein electrophoresis.
Right. In fact, I would add a prefix to test more. I would say, and especially for the clinicians, think more, test more, and treat less. So you have to think of multiple myeloma everywhere. Right, right, Dr. Ashwini. So coming back to you, so the next question to you would be, with the adoption of the terminology MGRS or monoclonal gammopathy of renal significance, how many nephrologists in the country are aware of this terminology, and how do you go about monitoring such patients?
Okay, so if you're talking about nephrologists, they all know about MGRS. So, though the chunk of patients are less, the incidence is less. It's almost maybe 1 or 2% only. But sorry, sir, can you repeat your question once again?
So my question was that the one you have answered is the awareness amongst the nephrologists for the terminology MGRS, and the other part is how do you go about monitoring such patients who are in the
So,
category of MGRS? How do you monitor such
right.
patients?
So once the MGRS is diagnosed, most likely it's the diagnosis is first they come to nephrologist for unexplained renal failure. It's a biopsy proven diagnosis, and after that we do all sorts of investigations and try to find out which clone it is. If we get it, well and good. If we don't get it, then also we treat it. As in now monitoring wise, as in terms of treatment monitoring, the treatment go as per the clone found. If we don't found any clone, as Rahul sir might agree with me, and he only treats all our patients. So B cell, plasma cell, if we don't get any, we give a combination therapy. And monitoring wise, first important monitoring is hematological remission, right? Whatever clone you have found, that should go in the remission. Obviously, renal parameters, if they improve or not improve. But there are many MGRS which may not improve even after treatment of, because many a times the presentation is very delayed. So even if you treat it, the renal recovery may not happen completely. So that doesn't mean that it is not subsiding or going into remission. So both the things needs to be monitored, both the renal parameters as well as the hematological remission.
Right. Dr. Rahul, would you like to add to the monitoring aspect of MGRS?
So whichever clone is there, you have to monitor. If there are free light chains, you monitor free light chains. If there's a B cell clone, you monitor it with a B cell clone. But the most important thing is to diagnose it. Diagnose
Right.
usually comes from a kidney biopsy. And another thing which I want to tell people is not to be afraid of a kidney biopsy in the hands of the right nephrologist. Right nephrologist, right lab, as Dr. Sujay Prasad is there. The most important thing is to diagnose the right, because kidney biopsy is a precious thing. For a precious thing, you need the precious lab. And that is why there are only few centers in the country which has now got specialized only for doing kidney biopsy reporting.
True.
Because right from a histology to electron microscopy, everything is now being done in the country. You can actually diagnose the rarest of the rare things. And the rare in this country of 1.4 billion is not rare. Okay?
Yes,
So
I
I
agree
think
with you.
the most important thing is when you have an unexplained renal failure, that is where the big five hospitals actually has an edge. Medanta, Max, Fortis, Apollo, these are the places where there's a trained nephropathologist. There is a lab like Dr. Sujay Prasad has, who actually specializes in kidney disorders to diagnose these rare disorders. So everything is not tuberculosis, everything is not diabetes, but rare diseases are now getting picked up, getting treated, and people are living longer. And that's why, dear friends, because of this constant dialogue within the doctors, we are hitting the age limit of 72 to 75. Remember, when we got independence, we were dying at the age of 35. Now,
35.
all of us who are listening, we will survive till 75.
I
True.
absolutely agree. Doing a biopsy just will not suffice. You should have a very trained person who can read the biopsy, and all three investigations, including electron microscopy, should be done, because there are few patients where, despite doing all of this, we don't find the answer to the which type of clone it is. We have even done mass spectroscopy also in couple of patients, which obviously goes outside India. We should do something about it, but yes, I would say it should be read by a good nepropathologist. Just doing a biopsy, you cannot believe on the report all the time.
No, correct. Thank you, Dr. Ashwini, for those inputs. So now coming back to Dr. Sushila Kataria, ma'am. Ma'am, my question to you is, being an internal medicine specialist in a big corporate hospital, how do you identify patients having a potential diagnosis of multiple myeloma in your clinic?
Thank you, Dr. Siddharth. So, multiple myeloma, we all are all from different specialties have gathered here, because multiple myeloma can present in any of these specialties. But the maximum chances that a multiple myeloma initially will come to a physician, to any general practitioner or internal medicine specialist, because the symptoms are going to be very general. The patient is not coming with a diagnosis, is coming tired, just not feeling okay, feeling pale, bone aches, urine is not good, or just saying that I'm not just feeling good, weight loss or
True.
fever. So we get a lot of patients, and it's not a very rare thing. Actually, I diagnose at least one or two every month. So this is
Right.
the, and a lot of other physicians like me are also diagnosing. And I would echo your point ki more than testing, it's thinking. By the time a patient goes to a hematologist or a nephrologist or kidney,
Mm.
some filters have already gone through, that he knows that probably he has a kidney disease, or maybe there is something wrong with the blood. But when the patient comes to a physician, it is the acumen of the physician with which a person suspects multiple myeloma. So, how I see is that any patient more than 50 years of age coming with anemia, I would see that it is something to be seen seriously. I mean, I would consider multiple myeloma, I would consider even colon cancer. And patients with a three-figure ESR, this is my teacher used to tell me, any
Mm.
person who's coming with an ESR more than 100, think of
True.
multiple myeloma. There are very few
Yeah.
diagnoses which you see with an ESR of 100. Or sometimes our pathologist, you order a peripheral smear and they say there's a roller formation. Or a combination
That's it.
of a deranged LFT, a low albumin, high globulin. If you have a calcium derangement, almost you're certain that you're heading towards that. I mean, you could have sarcoidosis and few more things. But I think how I pick up is that anemia in an elderly or 40, 50, we do not take it casually. First and foremost, ki koi anemia of iron deficiency and all that. So
Mm.
one is that. Secondly, then we look at our LFTs, we look at globulin, and I think an acronym can always help. ACRAB, any calcium derangements
True.
with anemia, with renal dysfunction, and bone pains, it has to be multiple myeloma and needs to be investigated timely with priority, and I would say more directed investigations. So I usually do this in my clinics to pick up multiple myelomas.
No,
So on the
very
lighter
correct.
side, the patient can come to all the specialities, but ultimately it has to be treated by a hematologist. So remember me.
So you are the
I think
end point,
Yes,
anything
the
which
Dr.
is
end
Siddharth, I do
solution
unexplained,
for.
remember you.
anything with the patient which is unexplained, especially at older age, should be suspected as myeloma. Literally anything.
Yes, but the
Absolutely,
unfortunate part
absolutely.
is,
And if there are
yes,
two specialties reaching at the same time to see a patient, so most of our multiple myelomas, Ashwini was with me, and if a physician and a nephrologist are seeing a patient together, then there is chances that it
Yes,
might turn out to
Higher
be multiple
it
chances.
might
myeloma.
turn out. Yes. Any multiple organ involvement, yes.
and the unfortunate part is, like Dr. Sushila Kataria said, a simple acronym like CRAB, which is easy to remember, easy to think by any physician, is somehow missed by physicians, not in the good corporate setups, but at, I would say, at the secondary level or at the primary level, where many of the myeloma patients do also turn up. So yes, the awareness of CRAB has to be very much amongst the overall physician strata in the healthcare system. So my next question to you, Dr. Kataria, is: will it be helpful if specific guidelines are created for general physicians to detect multiple myeloma, and what all can be done to improve awareness amongst them for the same?
I think absolutely yes. I mean, if we do not know it, we do not think about it, then we can't diagnose it. And as we said, most of the time the patient goes to physician for the initial symptoms. So making physicians aware that it is not so rare, it happens. There are patients. We sometimes come across patients who have been initiated on dialysis because somebody thought this is a chronic kidney disease and it is irreversible. So the patient goes on dialysis and on a maintenance dialysis. And unfortunately, a significant time has passed since the patient could be picked up earlier also. So making all the physicians aware, making all MBBS students in MBBS curriculum, actually all the rare and the common disease get the same weightage. So I think
Right.
this, but some diseases should get more weightage, and I think this could be one of these. And like simple rules, I remember by CRAB, and I always remember my teachers saying that patients coming with ESR more than 100, there are very few causes. So never ever, let this patient कोई नहीं, next time आना देखते हैं हो जाएगा दवाई दे दो. So this should be
Mm,
this. And I think we should teach our students very early that every anemia has a different etiology. Though iron
sure.
deficiency is the most rampant and most important cause of anemia in our country, but that's the not only cause. So I think we need to read our CBCs more properly. We need to interpret two investigations together. Somebody has a LFT and a CBC and a KFT. I think putting a kind of pattern into that and making our students aware, that would also be good. CMEs and
Right.
meetings and everything should be done in a very
Uh, Dr. Kataria, I believe we have lost you again. Hello. I guess ma'am's signal is not good. So no worries. Um, ma'am, ma'am, we cannot hear you.
yes, I can hear
I
you. I can hear you.
guess. I'm sorry, ma'am. I think again you are facing a signal issue, a network problem.
It should be good now. I think I'm good now.
I'm sorry, ma'am. No. Again, there is a disturbance at your end, ma'am.
All right. Okay, I think I have to
No
recheck.
worries, ma'am. I'll come back to you soon. So now I'll quickly go over to Dr. Puneet Girdhar, our orthopedician in house, and who sees many myeloma patients, because back pain is one of the common symptoms of myeloma patients. So my question to you, Dr. Puneet, is: as a spinal surgeon, what are the clinical features in your patients that makes you investigate for multiple myeloma by ordering a very simple test like serum protein electrophoresis? Dr. Puneet, you are on mute. You are on mute. Dr. Puneet, you are on
Sorry.
mute. Yeah, no worries. You are audible now. No, again, you are on mute.
Am I audible now?
Yes, you are
Yes,
audible
loud and
now.
clear.
Yes.
Okay, fantastic. So, as Dr. Rahul has very clearly mentioned, that we are the ones who should be avoided in a myeloma scenario. So I think he's very right. And the guy who made the criteria, or whosoever made it, the CRAP criteria, kept the bone at the last. And of course, you will want the orthopedic surgeon in a webinar also to be the last. Because ideally, our field should be avoided when it comes to surgery. But we understand the unfortunate part is that sitting in a tertiary center, I may not be representing the entire orthopedic clinic community, but most of the patients that I receive with fractures, spinal
Mm,
fractures. So either they are most of the patients are elderly who come with a very trivial injury, and your first suspicion amongst the whole ortho or the spine community is an osteoporosis. So that's the
mm,
first mimicry where we will miss the diagnosis, is that it's very easy to fall into the trap that this is an elderly postmenopausal lady and the patient doesn't have a significant injury, and the imaging shows typically some wedging, and you will easily label it as osteoporosis. And that's the first mistake we make. We do not bring myeloma to our mind because there is a complete lack of awareness, as I think it has been mentioned before, amongst the community, amongst the doctors itself, the healthcare practitioners. There are not many programs that being run if you compare it with a breast cancer or a lung cancer or many other cancers. So this is kind of neglected. One reason may be that it is very rare. So what most of my number one feature which I see as a spine surgeon is fractures. Patients present to us with fractures. Of course, there are criteria which show like this. There is a hunched back. There are patient has a stooped or a kyphotic deformity, and patient has multiple collapses. And the X-ray will show typically some punched out lesions. So it will become very easy for us to start thinking in terms of myeloma. Then there are other clinic patients who come and who has bone pains, and the pains are typically around the ribs, the pelvis, the hip area, and the back. And when you evaluate them further for their pains, more often than not, the patients which you get are for osteoporosis. But for all the patients that I receive as fractures, and they will either need some intervention because there are pathological fractures, they will need some cementing or some sort of procedure. So whenever we perform that, we always take a biopsy. It's mandatory in my unit here at BLK-Max that every patient who is being treated, elderly patient for a pathological fracture, we will take a biopsy, and we send an SP for all those patients wherever the suspicion is high. Of course, their kidneys are already screened because of the pre-op panel. Their hemoglobin has already been screened. But the foremost number of patients that we get, the criteria or clinical feature that we get is fractures. And you will be surprised to know that I actually treat one or two patients with spinal neurological deficit. That means there is a cord compression. So just imagine people not knowing that they have myeloma and they are landing with pathological fractures with neurological deficit, which becomes a surgical emergency. And why I think Dr. Rahul is very right that we should be avoided, because it's a menace for us also to actually do a fixation in a spine where there is hardly any anchor. So there are multiple bones and there's a marrow infiltration, and it is a very difficult surgical entity also for us to now fix this porous bone, myelomatous bone. And this is something that I also want to avoid in my clinical practice. And then we are looking for alternate options like cementing to strengthen our anchors. And also because myeloma is a disease, a spinal global disease. So you will not find many vertebrae which are spared. And many a times you get a patient with a spinal deficit and the patient has vanishing bone. There's nothing inside the vertebra. It is completely being eaten up. So it's a big surgical challenge for us. Now, a couple of things which we have done, I've told you, is that we get an SP the moment there is a multiple level involvement on the MRI. If we see that there is a marrow infiltration throughout, so we definitely think beyond. Means recently I got someone who is like 40 years plus and a female patient who comes in with a back pain and her creatinine is 4. And it's like a surprise for her. It's you don't expect that in younger people so often, but that might be an indication that if you have it in the back of the mind, because I have lots of myeloma patients being treated for spinal fractures in my practice, but that's not the usual clinic practice. It's an institutional practice. In a clinic, the moment an elderly male patient comes in, or even a female comes in with your hip pains and rib pains, which you're not able to explain in any other way, then we should have a threshold which is very low for getting an SP test. One unfortunate thing I've seen is that I myself at BLK-Max have instituted this, adding anybody who is more than 65 years of age getting a health checkup. We get a DEXA for postmenopausal women. So I think there is a role somewhere. I don't know actually. I think as there are more learned people on this panel, especially the physicians and the nephrologists and hematologists, where health checkup, are there any, is there any kind of health checkup that can include SP? Because all the health checkups have innumerable useless tests. I see all the time a huge file coming in, but one of the most important tests, SP, is missing, and usually it takes longer to get an SP result. So this is something I think needs to be figured out, how it can become a part of the health checkup.
No, I mean, very relevant. Yes, Dr.
I've
Rahul.
got two questions. What are these lytic lesions when people say, because people are listening from the tier 2 and tier 3 city also, can you elucidate on something on the lytic lesions? Can that be the first marker? Because you keep on seeing a lot of x-rays of the spine and the skull. And the second thing is, what is the cement thing? That kyphoplasty, vertebroplasty seems to be magical in your hand. That patient comes on a stretcher, and within 48 hours of a myeloma spine, he starts walking and starts getting the treatment for the myeloma, because your surgery, your spinal surgery, has made a difference. So can you elucidate a bit more onto that?
Yeah. So coming first to the fracture part, patients who are presenting to us with a fracture, we are doing the cementing part for the, even though there may be a widespread myeloma throughout the entire spine, we do the cementing for the vertebra which is painful and the vertebra which has recently become painful, and which shows on MRI signals of acute fracture. So there the patient has come to you because of fracture. So cementing will be a remarkable relief from pain. It's a pain management. While taking a biopsy at the same time in an undiagnosed patient for a pathological fracture will practically give us more power to rule out metastasis or a myeloma or some other entity. I have rarely seen even tuberculosis being getting diagnosed in a central TB, which is rare. So we make it mandatory to do that. So cementing comes in like a vertebroplasty, comes in as a pain relief measure, while it also gives us the ability when we go in with a needle to take a biopsy.
And is it complex?
And the other question, sorry,
Dr. Punit, is it a complex surgery? Because many people who comes from outside Delhi, they think that opening the spine is like opening the brain. Is it that difficult?
right,
Because I've seen a smaller
right.
incision, and I'm convinced. I
No.
mean, it does not take much of a time, and the people can be mobilized. What is your thoughts onto that?
I think this is a very good question that you asked. So, unlike our all other spinal surgeries, this is the easiest bit both for the surgeon and the patient. One, because it is done under local anesthesia. So, patient doesn't
Local.
have to be under local anesthesia. So, there is
I mean,
no
there is
spinal or central
no general
anesthesia
anesthesia.
required for a cementing procedure, whether vertebroplasty or a kyphoplasty. Second, it can be done in daycare. So as we all see, getting a bed allocated for yourself in a hospital is also a big challenge. So you can come in the morning, because these are not patients who are coming to the emergency. These fractures are coming to you in the clinic and they have the time, they don't have the deficit. You can call them at convenience in the morning under daycare and discharge them before the midnight. So they can go home on the same day. It's a daycare procedure. So and third, that this does not entail any major cuttings. It's a needle procedure. You just have to get your Jamshedi needle in, and everything will happen through that cannula, which is the part of the whole procedure as a working cannula, which goes on a guide wire. So, and it's an image guided procedure. There's nothing that you're looking inside. You're looking on an imaging intensifier and X-ray screen and doing the entire procedure. Patients usually walk out of the theater. It's practically walking out of the theater for patients who were having excruciating pain. The other question that you asked about the punched out lesions or the early diagnostic indicators on an imaging which is very easily available everywhere. So X-ray is the foremost thing that you can easily diagnose across the entire spectrum of primary or secondary or tertiary care. So the moment you have a patient who is coming in with bone pains and you get an X-ray, you will see these multiple round dark spots either in the pelvis. That's the easily identifiable. Whenever you get even a lumbar spine X-ray with a backache patient, you'll see part of the pelvis, and it will be so easy to pick up those dark spots on the X-rays, and that will give you the suspicion that probably we are dealing with a myeloma patient.
Yes. As the textbook display, whenever you have a myeloma chapter, a pepper pot skull image. So I guess that's one of the most common images which goes around with any
Correct.
myeloma literature. So my next question to you, Dr. Puneet, is, and I guess you have already spoken, but if you can elaborate a little bit more on it. As per your experience, what is the major cause for delayed diagnosis, especially in the orthopedic clinics for multiple myeloma in an Indian setting?
Yeah, I think as I've already said that number one thing is lack of any initiative on any agency, government, private, to actually make public aware, and also make our own colleagues, doctors, aware in every specialty, because myeloma can be picked up in an orthopedic clinic, a physician's clinic, a primary care practitioner. It can be picked up in a nephrologist clinic, so it can be picked in a specialist clinic. It will be easier. Yeah, orthopedics certainly need special attention because they are focused on the bones and they tend to miss the medical diagnosis very easily. So I think
Right.
the best thing you have done today is bring someone like me on board so that I also get more information regarding that, so that I can pick my patients early in the clinic. The other reason I feel delayed diagnosis is the vague symptoms. There's nothing specific, like everything is more like a senile situation. Patients come in who are 70, 65, and they have back pain, they have pains in the rib area, so they have pains in the hip, so which is easily being missed by most of the practitioners, even orthopedicians in the clinic, thinking that it is either osteoporosis or sarcopenia or some age related, and it's very easily swiped under the carpet by supplementing some vitamins and some other nutritional supplements and thinking that the patient would get better and not having a suspicion. So that's another reason that we miss this diagnosis very easily. The third reason I feel is that this is a relatively rare cancer, so it doesn't get that much importance, and that again will get us back to the lack of awareness. And while you see the number of initiatives for breast cancer, lung cancer, or for that reason uterus cancer, so multiple myeloma is not being talked about much, being a relatively rare cancer. And one point I already mentioned is that the lab tests, we have like innumerable labs today. So that's something I would request Dr. Siddhartha to formulate it as a part of the prevention strategy, which Dr. Rahul has been so categorically mentioning, and that it is the way ahead to have a healthy country. So it should be a part of some package where we enter serum protein electrophoresis. It's, I think, cheaper than getting a DEXA scan.
True.
And
True.
most of the, if you see most of the Western countries, I saw in Germany, England, post-menopausal 65 years, they're doing a DEXA for everyone because they're socialist countries. They'll end up spending so much more money getting those fractures treated out of their GDP rather than detecting them early and treating them with anabolic and lifestyle and treating them with easy calcium, vitamin D supplements and preventing those fractures. So that is one thing. And also, I think alternate diagnosis, like Dr. Ashwini mentioned, diabetes is very easily patients who have diabetes, they complain of bone pains, etc. So it's easy. very easily understood that probably it is happening because of long-standing diabetes, and nobody is suspecting myeloma in this setting. So those comorbidities are very easily confusing the practitioner, or we can say the lack of the ability to actually think beyond those high practice diagnoses which we see on everyday basis.
Right, right. So thank you, Dr. Puneet, for those inputs. And I believe you, Dr. Rahul, have laid a lot of emphasis on SPE as a part of a laboratory health package. And happy that we have the right person now to speak on this pertinent topic, that is Dr. Sujay Prasad, sir. And sir, sorry to have kept you waiting, but it was the clinicians who were doing the talking, and now the laboratory jumps in. And my question to you is, as you have been a pioneer in incorporating SPE as a part of your laboratory's advanced health package, and I believe this was done 15 years back. So, can you share your experience on how useful it has been for picking up patients harboring multiple myeloma?
Thank you, Dr. Siddharth, firstly for having me on this panel, and it's an honor
You're
to be
welcome.
here. I've thoroughly enjoyed the last 45 minutes because two things have happened for me. One is it has reinforced my understanding of myeloma. Secondly, I have got nice viewpoints from the specialists on this panel. Thank you so much for that.
You're welcome.
Having said that, interesting question. When we look at, we introduced electrophoresis as part of liver function test. This was in 2000, between 2008 and 2010. And the intention of putting SPE in LFT was primarily to understand the protein synthesis pattern other than just albumin globulin, because
Right.
typically in LFT has albumin and globulin, nothing more. But the moment you introduce SPE, it becomes much better, much more sensitive. And we started to pick up renal pattern. We started to pick up cirrhosis pattern, inflammation, both acute and chronic. So we started to see many things. So interestingly, it was not myeloma that we introduced protein electrophoresis at that time. But
Okay.
as we started to experience LFT based SPE, we started to pick up uh, monoclonal proteins, M spikes.
Oh.
Now, when I look at the statistics over the last 10 years, we do almost about 13,000 protein electrophoresis a year, and 2% of them show an M spike. So we are talking almost of 20 per month where we pick up monoclonal M spikes.
M spikes.
Now, yes, most of this turn out to be MGUS, but some of them, anecdotally, there's an elderly person who came with for a general health check. He was taking neck massage for a pain in his neck, and then the electrophoresis shows an M spike, and then he
Oh.
got his X-rays done, clearly showing all the light effusions. He was, meaning it turned out to be a multiple myeloma. But fortunately for us, of the 20 per month that we see, not all of them are like this. Most of them are monoclonal gammopathies of undetermined significance. And the good part is then they get to know that they have to monitor it. So
Right.
they get it done once in 6 months. And then it's been an experience because my colleague Dr. Prajwal also looks at whether it's a non-IgG type and if it's an IgM type, because it goes on for IFE,
Right.
immunofixation. And that helps understand whether we are talking of the IgG type or the non-IgG type. So overall, the experience has been good introducing the protein electrophoresis into the health checks, because apart from M spike, we also pick up other patterns that may help in the clinical scenario.
Right. Right. No,
Dr.
thank you.
Siddharth,
Yes, Dr. Sushil.
I would like to make a point here, and I think that point has been very clearly delineated by Dr. Sujoy also. So I would not think that adding one more investigation into our preventive health checkup, it's going to increase the burden. Look at this, 13,000 investigations are being done just to pick up one multiple myeloma. It is not cost effective, neither it becomes a part. What is required is just observation. Maybe that multiple myeloma could have been picked up by doing a CBC and an LFT also. So I think adding one more extra investigation to already, heavily loaded preventive health checkup, how much of that is really preventive and how much is this, I mean, this is leading to health anxiety also among people. So we have to look at that angle also. I may be an outlier in this whole panel to say that it is really not required to be a part of health checkup, but yes, one has to be watchful. What we are already doing, the basic investigations can tell you more.
Thank you,
I
madam.
think Dr. Sushila, you have raised a very valid point, and Dr. Sujay,
Right.
Dr. Sushila, I'll slightly beg to differ with you. Why? The reason is, if you see the Iceland, they completely
I
eye-stop
stop.
myeloma
I
trial.
stop.
They scan entire population to understand at what stage the pre-malignant clone is rising from. Now, as the health checkups and the longevity is increasing, the myeloma, if you pick up MGUS, where you don't have to do bone marrows every time, you don't have to do the PET scans, just a simple protein electrophoresis and a serum ferrite chain, you can continue monitoring because 1% of these patients will develop into myeloma. Second thing, through a health checkup, 1 in 1,000 SMMs you like to pick up, smoldering multiple myelomas before they go and hit your kidney or your spine. So the most important thing is, can I do a simplistic test for picking up these and understanding the natural history of the disease? For me as a researcher, because now we have an advanced center for myeloma research, at this present moment of time, we are seeing these clones starting at the age of 40, 42. And this will be revealing for all of us. Just to digress from this thing, as we have a center for genomics, we have got everything 15 years younger, and you have got Lynch syndrome being picked up. We are younger people. Why should we have disease? Now we are saying we have more inflammatory markers. We have got diseases which are occurring younger. We have got 2.3 times more mutation than the American counterparts. So you see, all these health checkup data, once put on into AI, will build up a very robust model of understanding of how we deal with diseases as we live longer. Because right now we might not be seeing the surge of expenditure which is going to come to the country as we have start getting more aged population, which through Americans or the Europeans is going through. So probably we might not be able to change many things, but at the same time, if we have got a 10,000 patient data between five big five hospitals like us, we'll be able to change something into the space of myeloma in a decade. And that's why we have kept a whole decade, one decade long journey till 2035 for a myeloma advanced research center. And that is why the mass spec is coming, because the mass spec will make evaluation at say 100 rupees. So from 350 rupees, it will boil down to 100 rupees. So I think that's the whole.
I agree with you, Dr. Rahul. It can be a part of a research project. Doing on 10,000 patients as a part of research is acceptable, but making it a norm to screen every person every year with SPE is neither it is practical nor it is cost effective.
I think there is a point here to add is that you will definitely need a cost benefit trial. Cost, like what Germany has done is that DEXA is not going to be a part of the. I absolutely understand the anxiety of Dr. Kataria that this is going to be another financial and of course a social burden, but a cost benefit analysis will actually bring us to the conclusion that who are the high risk people who will actually need this health checkup. So like it is designed like serum prostate specific antigen, the difference it has made, but that doesn't mean that we are doing a serum prostate specific antigen in every health checkup. So what Germany did is by adding the DEXA to 65 plus postmenopausal women, so those women will, their cost benefit ratio shows that the burden of those fractures and the costing would be much higher if they are left undetected osteoporosis patients there. So same would happen probably in myeloma, is that your primary health checkup physician there or who is in charge of the health checkup center would be able to assess clinically and suggest that this is the package for you, and you need to get this package done, like we do for pap smear or we do for other precancerous detections.
No, very well put, Dr. Puneet. And I believe it's the high risk patients with definitely which would need a more extensive workup with SPE, definitely. So, just for the general information, I guess we have almost touched time. So, I would be a bit quick in ending this session. And my last question to Dr. Sujay would be, Dr. Sujay, sir, in your vast experience, can you talk on how relevant a good interaction is between the laboratorians and the clinician to help in early detection and better patient management for multiple myeloma?
Thank you, Dr. Siddharth. I think I can't overemphasize that aspect at all. We are a standalone lab in the sense we are not a part of the hospital, yet we find it so relevant to get information about the clinical setting in which we are seeing the pattern on, say, even serum protein electrophoresis. Because we see an elevated beta 2 and we are trying to understand what are we dealing with here, because the pattern, if it's happening in an elderly person, then we do not want to miss out an M spike in the beta 2 region, though there are other normal proteins in that area. But we clearly pick up the phone and try to get as much information as possible. So uh, in the setup that I am, it's always a challenge to get the relevant clinical information. But in a hospital setup, I'm told that it is really easy because you have the hospital
Correct.
information system. You have all the information in the hospital information system, but at the same time, picking up the phone and talking a few words also, like how it has happened for me over the last 1 hour, I get different perspectives, and I think
Right.
that immensely helps.
Yes. So there
Dr.
is
Siddharth, can
Absolutely.
I
And
can
I
I
think
yes,
say
yes,
Tina,
just
Dr.
one thing? Dr.
Yes,
Siddharth,
Dr.
can I
Puneet.
just say
Yes,
one
please
thing
go
for
ahead.
a
Please
laugh?
go ahead. Please go ahead. Please go
Yeah,
ahead.
it's just for the last laugh. It is that you ask this question, how this clinical and laboratory coordination can get better. So I'm in the best scenario, get married to a hematologist.
I was expecting
So I
something
think
like
a
this.
lot of people help me.
I was.
Those who couldn't make
Keep-
out this, that my wife is a hematologist, Tina. So I think I'm blessed here.
You have
And
an
Dr. Siddharth,
extremely
one
good
more thing is,
interaction.
so out
And
of this,
Yes,
I
yes,
have
and
come
the
on.
icing, Dr. Rahul, icing on the cake, we both work in the same
Same
hospital.
hospital.
So,
Yes.
so it is a professional as well as
No, no.
personal, both at home and in office. Myeloma cannot go undetected.
There's no escaping for myeloma. True.
Yeah.
Yes,
at the
Dr.
end
Rahul,
of the
you were saying.
discussion, I really don't know who should be my best friend, the nephrologist, the internist, or the orthopedics. I would say all should be the very good friends because myeloma will continue to come to hematologists from all across.
So,
But
Dr.
thank you,
Rahul,
everyone. I think it has
yeah,
been a great insight for a surgeon too. Like we are the always the backbenchers. At least considered the backbenchers.
no, no, no. I guess you are in the fronts and more so when it comes to myeloma, especially. So, Dr. Rahul, I guess we are above, way ahead of time. Just a quick take home message for the audience as well as the panelists out here from your side.
I think it's a evolving field. We need to keep the diseases on our radar. Is highly focused and a precision time where we are dealing with. And these big five hospitals are into the capable space right now to deal with any difficult or a complex situation at this present moment of time. So I think most important in myeloma remains the awareness. And if you have the symptoms, please connect with any of these great doctors or the specialists so as to sort out your problem. And I would still believe test more, treat less remains the motto at Fortis Institute of Blood Disorder.
Right. And serum protein electrophoresis, however, the opinions may vary, still remains a very simple test which can give you a lot of information if required, more so when you are strongly suspecting a myeloma patient. So, with that, I will bring this panel discussion to an end and thank all the panelists for the time they have given for this informative session and very great take home messages for the audience. So, thank you all for your presence, and I'm grateful for all of you to have attended this session. And now I'll give it back to Simran to have the concluding remarks. Over to you, Simran. Simran. I guess Simran is not there. So I guess then we can conclude the session. So thank you very much, all of you. And thank you, audience, for participating in this great virtual session. So have a great evening ahead and great evening ahead to all of you also. Thank you so much.
Thank you,
Bye-bye.
Dr. Siddharth. Thank you. But Simran went with Raj. She voted for Punit. On that DDLJ note, I would say thank you, everyone. Thanks a lot. It was
Thank you, Dr.
Thank
Puneet.
you,
Thank you, Dr.
thank you,
Ashwini.
thank you,
Thank you, Dr.
thank you,
Sujay.
thank
Thank
you,
you, Prasad.
thank you, thank
Bye-bye.
you. Bye bye, bye bye, bye bye, all.